I would like to thank James Burton for giving me to this opportunity to present the host topic today. I'm Dr. Thang from DSA unit from the SAS Cần Thơ Hospital. But before telling you about our study, let me talk about some background information. A- After the success of 5RCT, Mr. Kling escaped Rivakas Swift Prime is 10 IA. They also recommend mechanical thrombectomy is the first line to treatment the AIS due to the lavascular occlusion. After the five success, five RCT meta-analysis has mastered, they recognized the failure of the mechanical thrombectomy recanalization account for the 28.9%. And especially in Asia, as you know, the intracranial arterial stenosis account for 30%. So we if we meet the mechanical thrombectomy if fail, what should we do after that? Rescue intracranial could be the alternative to get the permanent recanalization. Therefore, the aim of our study were to assess both the non-poor outcome at treatment and the symptomatic ICS relating to the procedure in patient reaching the rescue intracranial stenting. As you know, there are the 130 billion neurons in the normal brain in adult. So if treatment fail to occur each hour, the brain loses as many neurons as it does. It's almost the 3.6 years old of normal aging. So the time in brain is very important in acute ischemic stroke. To realize the aims, how did we go about investigating this? We register our study in a clinical trial, and there were the 85 eligible patients from the August 2019 to May 2021. And inclusion include that one, evidence of intracranial lavascular occlusion, two, absence of intracranial hemorrhage, three, severe stenosis or reocclusion after the mechanical thrombectomy. And inclusion comprise of a tandem lesson, loss of follow-up after discharge, and a severe combined illness before AIS. We define the variable. La intracranial vessel comprise of ICA, MCA, VA, and PA. Recanalization failure was defined MTC less than the 2B. Non-poor outcome comprise of good and fair. If after the angiography we recognize the severe stenosis or reocclusion after the mechanical thrombectomy, we use the 300 milligram clopidogrel and 162 milligram aspirin via nasogastric tube. And MRS treatment, we evaluate the patient by a phone interview. It's the the diagram of our study. It's comprised of the 18 severe stenosis and 67 occlusion. Now, let me turn the interesting result and show you this important of our study. MR, MRI Tesla allow us to diagnose occlusive lesion uh, about 4 times as many as a phone positive ratio. Thanks to the SWI sequence, we could say the total procedure time to differentiate lesion at admission between intracranial stenosis along and thrombus together with one, such as it allow us say many times to repairing and setting up the interventional device at the outset of procedure, which could decrease number of cases with total procedure times more than 60 minutes, concerned with poor functional outcome. This is the thrombus in SWI sequence in the MCA. It's the occlusion MCA in DSA. This is thrombus. And after recanalization, there are the aspect in anterior and BC aspect in posterior lesion. The WI aspect if less than 8 point, it relating the poor outcome, and PC aspect less than 6 point, it's also relating poor outcome. This was distribution of stenosis liver from severe 80.8 and percent were occlusion, and to 96.5% my stenosis. This was the distribution of MIS after procedure. We evaluated the patient treatment non-poor outcome make up the 55.3%, and death it account for the 18.8% after treatment. As you see, smoking was a remarkable risk factor and relating to atherosclerosis and occlusion. As you see, rehabilitation after procedure could delay the process patient recovery. In spite of the successful recanalization, stroke rehabilitation is responsibility of representatives and physicians who support them to limit high risk of the deep venous thrombosis and pulmonary embolism. There was the factor relate the mortality and poor outcome. AF-CKD, dysphagia, posterior circulation, symptomatic ASIASTA, and decompressive craniotectomy. There were the a patient. They used RTPA after before procedure. We recognized a patient no complication, no symptomatic ASIASTA, not associated with a poor outcome. There were a patient have a complication with relating to procedure. Three patient new infarctor, 4 symptomatic ASIASTA, and 1 person metabolic acidosis. Following the ESO guideline, They recommend the patient was use the data within the 24 hours with help the patient the effective and safe more than the monotherapy. Especially you see the anterior circulation have relating to the good outcome, and posterior circulation relating to the poor outcome. We think because only if a severe symptom of ischemic posterior lesson, such as the onto consciousness, dysphagia, and ataxia, it make the patient were hospitalized to be recanalized because their initial symptom in relating to posterior circulation was the mild, were mildly, such as headache, vomiting, and dizziness could be present early and mildly, but they less obviously than one in anterior circulation. They were to study to comparing the non-stenting and rescue stent, and they recognized the rescue stent relating to the good outcome after procedure. The good comparing the other study, the result of our study were the more than and good good better than the other study. And the complication symptomatic ICS in our study less than the other study. It account for the 4.8%. There is the case report the man 67 years old, still onset the 7 hour. The symptom is stable global aphasia, hemiparesis, facial paralysis, needs 23 point. After the angiogram, they recommended the occlusion, the MCA. So after mechanical thrombectomy, the MCA is dissect. So and they rescue stenting immediately after 5 minutes waiting. Post procedure MIS discharge 2 point and treatment normal. I think that's the result of presented so far can allow to make the following point. First, time is brain, and so we have to prepare the imaging finding best to save the time and to decide the intervention or the RTPA immediately to protect many neurons as much as possible, and the data we can use early to shock book or to protect and to help the patient better. And if acute ischemic stroke in anterior lesson, we it relating to the good outcome, and MRI treated can be useful and save time and with help us to release a lot of information. And rescue intracranial stenting could be alternative procedure to get the permanent recanalization. And finally, rehabilitation is the important to return and to have the patient independent in spite of the successful recanalization. I would like to conclude my presentation by expressing my appreciation to the following college in this line. Thank you again for your attention, and I'm happy to take your question. Yeah, thank you.